moving things along. I don't need to reintroduce Johanna. We've all heard about it. So does double checking reduce medication administration errors? Interesting question.
Thank you very much, George. So this presentation is really an opportunity that we took while we were doing this direct observational study of nurses. I think, first of all, we would like to thank those almost 300 nurses at the hospital who allowed our researchers to follow them around during the wards. It was an incredibly generous of them to allow us to do that. So one of the things that we were able to do, which is Magda pointed out, is not only look at whether there were errors, but look at the procedures that the nurses were undertaking. So let's think first of all about double checking and as a policy. Internationally, it is used extensively, and the overall assumption is that if you have two people checking, at least one of them's probably going to pick up an error if it's there or not. And so 2 nurses are safer than 1. That's the overall assumption for this safety policy. So what's the evidence that when you have 2 nurses checking, you get fewer errors? Well, we did a systematic review, and it is perhaps surprising to find that there is very limited evidence of studies which have shown an association between double checking and fewer errors. There are a number of qualitative studies where they ask nurses about their experiences of double checking, what are some of the challenges, and clearly we all know it takes a lot of time. You've got to go around and find a second nurse, you've got to interrupt somebody from what they're doing, and we know that interruptions can be associated with errors as well. And often when you ask nurses about the policy of double checking, some organisations don't really have very clear policies. They just say you need to double check. But what does that mean? Which elements of the process should you double check? Independence in the checking process is seen to be critical to the effectiveness of it. And this is where you have both nurses independently undertaking all checks in the process. And the Institute of Safe Medical Practices in the US, who are supportive of this practice, talk about, well, you have 2 people working independently, they're less likely to make the same mistake. If they work together or suggest to the checker what you should find, both could follow the same path to error. So the opposite to independent double checking is this notion of sort of primed double checking or collaborative double checking. And this is when the nurses share information. So I might hold up a vial to my colleague and say, morphine. So you have primed them to see morphine. So we were interested in identifying whether nurses who double check, or do nurses double check, and is it associated with fewer medication administration errors and also lower severity. And this was part of the stepped wedge study, but also we extended the data to weekends as well. Now, the hospital has quite a clear policy about independent double checking, which clearly states the most critical aspect is to maximise the independence of the process. They also have these great step-by-step process for what the checker should do and what the requesting nurse should do. These are the medications that don't need double checking. It was easier to put that list up than for all the other drugs. So most drugs in the hospital require double checking. So just to extend it on what Magda was saying, it's a slightly larger study because we included weekends, over 5,000 dose administrations. The observers recorded what they saw to be administered and prepared, and then that was compared with the patient's medication record to see whether an error occurred. But we also measured whether the nurse complied with double checking. So here you can see on the POSSUM data collection process, we recorded whether the double checking process was independent, whether it was primed, or whether it was incomplete or not undertaken at all. And as you know, this is how we came up with the errors and the error categories we've heard about. The analysis we did, for those of you who would like to know this detail, is a generalised linear mixed models to examine the association between double checking and the occurrence of an error, and double checking and the potential severity of those errors. And we needed to adjust for a whole range of factors because nurses of different experience, different patient details in terms of their age and gender, whether it was a weekend or a weekday that we were observing them, whether they had EMM in place or whether it was still using the paper medication chart, and we also looked at time of the day. So this is what we found. So of the 5,000 medication dose administrations, nearly 70%, 69% of them were required by policy to be independently double checked. What we found was that no double checking occurred in 6.5%. Independent double checking occurred in 36 instances, or 1%. And prime double checking occurred 93% of the time. So if prime double checking was the policy, that's incredibly good compliance with a health policy. So what we did was we combined those two categories of primed and independent, and we found that there was no association between double checking and occurrence of an error or the severity of an error. Now, we also looked at those medications, around 1,500 dose administrations, where the nurses were not required by policy to double check. And what we found was that no double check was undertaken in 74%, which is fine. 7 cases there was an independent double check, and about 25% of the time, nurses chose to double check anyway. And there we found that there was a significant association. So if they chose to double check, there were fewer medication administration errors and they tended to be less severe. So the summary of the findings is that prime double checking was no superior to not checking at all. But these very interesting findings that when nurses weren't required to, but they made a clinical judgment about they wanted to double check, we found fewer and less severe errors. What were some of the factors that we found were associated with double checking when it was required by policy? Well, we found the orthopaedic wards tended to have a higher use of this double checking process. RNs were more likely to double check than ENs. Weekend, more likely to double check than during the weekday. And compliance tended to be a bit lower with EMN versus paper. But remember, this was also during the first 70 days of use. So some of those factors, such as the weekend, may be just a factor of having the time to do the double check. Factors associated with optional double checking was that nurses who had fewer than 2 years experience were more likely to get a double check done. If they weren't multitasking at the time, they were more likely to double check. If they were using a paper medication chart, if they were administering after 6 in the evening, and if they were using a route other than oral. So all those sort of factors suggest having a little bit more time and recognising perhaps you don't have the experience and you need some support in that process. I think overall it's important to note that with the mandatory double checking, the error rate was much higher than the error rate for the optional drugs, and that's partly a reflection of the more serious medications that require double checking. We also looked at the time involved. So for 800 dose administrations, we were able to measure how much time it took for just the second nurse to come along and do the double check. And on average, it took 6.4 minutes. And we know that there are around 1,800 administrations at the hospital per day. Almost 70% of them require double checking. So each day it consumes around 133 nurse hours. So probably 13 to 15 nurses full-time are using their time to double-check medications. So really, this research left us with more unanswered questions than answered questions. Does independent double-checking reduce administration errors? We don't know, because it's done so rarely that we couldn't measure that effect. And I think that also tells us a lot. Is the question, should we really be assessing the scope, the value and the opportunity costs of double checking? What could we use those 13, 15 nurses for? Or if we halved it, what could we use them for in terms of other safety activities? And that comes down to maybe we should be a little bit more targeted in how we use this process. And it also, for us, raised the question, well, what new evidence do we need to move policy and practice forward? I think the other thing that we need to consider in terms of the research is all the factors that might impact on whether somebody double checks in the way that we expect them to. So we know hierarchy might have an impact. So if you've got a senior nurse who's checking with you and you're a junior nurse, are you going to challenge that nurse? There's a lovely term in psychology called social loafing, which means that if I think you're checking, then I don't really need to do it very well, and you think I'm checking, so you don't think you need to do it well. So sort of distribution of responsibility. We know interruptions are a major factor here. You're interrupting somebody else to do their work, and we know that's associated with errors as well. And there are also some people that are just more vigilant than others. And so there may be certain characteristics of individuals who may be better at double checking than others. And the other thing that we need to recognise is the context of medication safety has changed dramatically. So we have medications packaged in new and different ways. We've got new technology, smart pumps, automatic dispensing machines. So the cognitive demands on nurses are quite different to those 50 or 60 years ago when double checking really started to be used. So I do think it calls into questions. We continue on a whole lot of technological advances, but we stick with the same policies we've had for the last 50 or 60 years. And I think it's imperative on us really to start challenging and thinking maybe they need to be updated as well. So what are the next steps for us? We're really pleased that the Children's Hospital is keen to further investigate this issue. And the first step in that process is we really want to answer the question that if you did the perfect independent double check in a controlled environment, does it actually produce a better outcome? Because no one has answered that question yet. And so one of the things we're currently doing is going to run simulation and experimental studies to answer that question. And this is certainly not just a question that we here in Australia are answering. We've got colleagues in England, in Norway, who are equally questioning when should we use double checking and when it's not particularly valuable. So if you'd like to know more about the details of that study that's published there, thank you very much.
Johanna? We do have time for a couple of questions, and I'm guessing double checking was probably a lot easier in Florence Nightingale's time than what it is now. So that complexity is probably part of the challenge ahead of us. Go ahead.
Thank you. Miriam Lawrence here from Calvary Hospital in the ACT. We're about 50 days out from going live with a complete territory-wide digital health record, so this is very timely.
What are you doing here?
Escaping.
We snuck away. I'm really interested to hear about your thoughts on the involvement of barcode scanning at the point of administration with these administration errors. and also on the level of decision support, I guess, that's in the electronic system to give guidance or advice about the best way to administer a medicine and how that may impact this.
Okay, two very big questions. I think the caveat, first of all, is we haven't done personally a lot of research on barcoding technology, so there are a number of papers out there that we could certainly direct you to, particularly in the US. It certainly, there seems to be evidence that it is valuable in reducing some of these errors, though classically clinicians are very good at workarounds, and there are some nice US studies where you have, poles in the medication room with all the barcodes of every patient stuck onto it to improve. And I think that's a clear example of where you've got to get the technology to integrate into the workflow. It just became too inefficient the way they'd set it up. And so the nurses needed to be efficient. They need to get the drugs to patients, which is a priority, and so they took that. And then in terms of decision support and information about administration processes, that is, that's a core challenge for all aspects of the system. How much do you put in? How many alerts? You can create lots of sections for information, but it has to be up to date and you have to have the time to read it. So, good questions. I don't have the answers. Maybe Mark has some of the answers.
All right, Mark.
Look, it's a fantastic topic, and from my experience as a director of EM services, something similar to it was we couldn't even get the senior staff in the hierarchical structure when there was handover between ambulance to nurse, receiver to then junior, then senior medical. Once they'd made a decision, it was very difficult to get people to question or check or challenge. So I think that whole hierarchical is so powerful, and we've seen many examples of that when you've got people in perceived power. To counter or to check that is so challenging. But again, the likes of human behaviours that we touched on in some of the earlier ones, we know in our nuclear age, it requires a separation of two people to turnkey. There are design features that I think the challenge here is to how do you gain that independence of each other, that there isn't that lead behaviour and or looking over. And we've even got design features for safe delivery of controlled medications. And if Aaron from Sydney was here, they've even given it a name of how to bypass it. It's called Roger Rabbiting or top boxing. So there's even names for these types of workarounds, which is a little disappointing that it even has its own colloquialisms. But I think to come to those challenges, these are fundamentals of human behaviours, human-centred design, not only as what we're trying to achieve, but also you're really moving against some of those incredibly powerful behaviours. We know this from all professions, but it's very difficult to be in a close working relationship and then to say, I think that's wrong. That takes an immense confidence, and I think that's where some of the near future digital design of having the mobile rather than the aggregate around a single WOW or device, where we can actually have some physical separation. But there's a lot more to happen here.
Yeah.
I'm sorry to say, Johanna.
And I think you make two really good points. I think partly with the hierarchy things, one of the things we learnt from those second set of results is that clinical judgment is, maybe quite accurate, that, even the inexperienced nurses knew that it might be useful to get a second checker. And so sometimes freeing up practice, rather than dictating in policy, you must do this every time, is actually relying upon the expertise of the staff and perhaps not fooling us. The issue of is independent checking actually practically, feasibly possible on busy hospital boards, and are we fooling ourselves a bit to keep on holding up and saying you must do independent double checking when everyone knows that it's not possible? So, I think we need to have that conversation.
Cliff Hughes from Macquarie. My question is about the second nurse that gets called. We know that interruptions are bad for quality and safety. Did you actually have a look and see what that person was doing when they were interrupted to come and check the nurse? No,
we would have loved to do that. And I think we sort of maybe naively thought it would be pretty straightforward to do a direct observation study and just tick off, did they double check or did they not? And the complexity of it was massive. So a great point, but no, we couldn't answer that question.
Question over here.
Thank you. Silvana Owd from eHealth New South Wales. Thank you, Johanna, for the research and information. I guess I'm particularly interested in the group of nurses who elected to consciously go and do a double check even though it wasn't mandated by policy, and why what were the characteristics of those situations, those medications? Why weren't they identified as opportunities for double checking by policymakers? So was there an opportunity to delve deeper with those groups to understand what constituted self-identified triggers for double checking, and is that something we should be teaching rather than mandating double checking for certain high-risk medications?
So, great question. I think all we've got is the characteristics of when did that happen for non-mandatory double checking. So it seemed to be that generally, so experience was a clear thing in that group, and also the fact that when they had a bit more time, so they weren't multitasking, it was a slightly more complicated drug, so they didn't do it with oral drugs, but they did with... But obviously that was a sort of, they were only administering certain types of medication. So we've got to be careful not to draw too much from that as well.
I'm assuming these weren't closed-loop medication administration systems,
No.
so these were the Australian models. So in the US, where they use closed-loop medication, is there any data from there at all? Not specific on that,
not with
but
double checking,
yeah.
no, it's amazing.
Probably sneak in one more question. I think we had a question.
I think there's one at the back. I think she's
Just
been
want to
up
grab a
for while.
microphone
I think
wins.
this one I've had for a while.
Okay.
Just hang on a second, Madeline.
Kate Callaghan at St George Hospital. This is a very big interest of mine, and it's such an old issue trying to get good compliance with proper, independent, complete double checking. And I can understand why you have so much difficulty answering that critical question. We tried to approach this issue from a completely different angle a couple of years ago. We thought, how can we bring some innovation to this and just make it not less a compliance issue, and have, if we can have some grassroots kind of solution design from the actual operators within the system. And some of the innovation we brought to that approach was, if we educate the operators of that system in some of those socio-technical factors that you've mentioned there, everything from the way your brain works and doesn't work when you're multitasking, through to the social loafing stuff, cultures within teams, and all the vulnerability factors, everything from the hungry, angry, late, tired stuff. And we did some education around that and then supported them to come up with some of their own solution designs. We found it was only just a basic quality improvement project at the beginning, so it wasn't research quality necessarily, but we did end up finding, after that intervention was applied, we decreased the number of medication administration errors involving missed or ineffective second checks by a third. And we wanted to follow up some months afterwards to see if that impact had been sustained, but unfortunately COVID hit.
Yeah.
So we do want to do some further research into that. So I guess my question, very long-windedly, is just asking, are you aware of any research into whether educating operators of a complex system or process, focusing on those other socio-technical impacts on their own behaviour has an outcome that could be positive?
So the short answer is no. It sounds like a really sensible and interesting approach. There are certainly, I know I'm in contact with some groups in the UK who are starting to target double checking and looking at what's the education around that needs to support that process. And certainly one of the areas we want to take this is to test different interventions and different approaches to this, and really talk to people who are at the front line about this. That sounds like a really interesting approach. So I think a lot of scope, sounds very interesting. Love to hear more.
A simple question: would having more nurses on the floor make a difference? I mean, that's
to do what though? Do we want more nurses to double check, or maybe more nurses to do other things?
Or just more nurses.
Yeah,
All those
nurses.
in favour of more nurses?